Hello, my name is Dr. Norman Lepore. I'm a clinical professor of medicine at the David Geffen UCLA School of Medicine, attending cardiologist at the Cedars-Sinai Heart Institute, and co-director of medical discovery at Westside Medical Associates of Los Angeles. Today, I'd like to speak to you about a very important topic, cardiac amyloidosis. It's right in front of you. And I'd like to show appreciation to Dr. Bukhari, who assisted with putting together this important presentation. So what is cardiac amyloidosis? It's a progressive infiltrated disease caused by the extracellular deposition of amyloid fibrils. These are misfolded proteins, and this infiltration occurs at the cardiac level, resulting in a restrictive cardiomyopathy. What you can see here in this particular slide is the actual extracellular matrix, which is composed in this particular situation with amyloid, of this amyloid protein. And on the left, you see these specimens of hearts. They're very thickened, but it's not as a result of left ventricular muscle hypertrophy, but actually related to the deposition of this amyloid protein, creating a restrictive cardiomyopathy. So what is cardiac amyloidosis? It's a myocardial disease characterized, as mentioned, by extracellular amyloid infiltration throughout the heart. This process results in biventricular wall thickening with concentric ventricular remodeling and a low cardiac output. The subsequent elevation of pressure in the atria is associated with atrial dilatation, both the right and left atria. Even myocardial vessels are frequently infiltrated by amyloid, causing reduced myocardial perfusion. The conduction system is also frequently disrupted, leading to atrial arrhythmias such as atrial fibrillation, atrial flutter, or atrial tachycardia, as well as atrioventricular conduction delays being seen quite commonly. So let's look at the amyloid nomenclature so you can understand what these abbreviations mean. First of all, the letter A is for amyloid. That's easy to understand, referring to the main type of protein being deposited. The L after the A is for light chain amyloidosis, and we'll get into that in a little bit. And then the TTR after the A represents the transthyretin amyloidosis, which is what we're going to focus much of this presentation on. So this gives us a nice view of the pathobiology of this transthyretin amyloid. First of all, this protein is made by the liver, and we can see it's expressed initially as a tetramer. Then it becomes folded into two folded dimers. Then you get this folded monomer. So now you're going from the tetramer to a folded dimer to a folded monomer. And then you get to really what you start seeing as the amyloid protein, this misfolded amyloidogenic monomer, with eventually being deposited in organs such as the heart, creating the cardiomyopathy, or in the nerves, leading to either peripheral and or autonomic neuropathy. Those are really the main two manifestations of amyloidosis. So let's look at the prevalence of the different amyloid types. First off, greater than 98% of diagnosed cardiac amyloidosis results from the fibrils, which we talked about being composed of this amyloid protein. We have the monoclonal immunoglobulin light chains. Remember, that's the AL type. Then we have the transthyretin, and this can either be hereditary, meaning a genetic variant, or acquired, meaning the wild type. The wild type meaning that which you were born to, a non-hereditary type situation. So let's talk briefly about the light chain amyloid. So antibodies are composed of heavy chains and light chains. And when a plasma cell becomes clonal or malignant, it can actually clone for a particular antibody. And this leads to an excess of light chains. And it gets to the point that you can actually have three possible outcomes from this pathology. First, if the plasma cell clone takes over only a small portion of the bone marrow and the light chain is harmlessly excreted into the urine, this is known as a relatively benign situation called monoclonal gammopathy. If the plasma cell takes over a larger portion of the bone marrow, potentially leading to hypercalcemia, anemia, lytic lesions in the bone, and or renal dysfunction. This is a disease state we all have heard of, myeloma. And if the plasma cell produces a light chain that is prone to misfold into what we call beta pleated sheets, these light chains circulate in the bloodstream and deposit in one or more tissues. And this is what we would call the light chain amyloidosis. So let's talk about transthyretin and what it really is. First, it's really known, previously known as prealbumin. It's an abundant protein that is produced by the liver and basically functions as a transporter of thyroxine and vitamin A. It circulates predominantly as a homotetramer, as we saw in that previous slide, with a small amount circulating in a monomeric form. This monomeric form of transthyretin is prone to misfold and gradually deposit as amyloid deposits. In the wild type, that's the non-genetic type, or the non-mutation component, the TTR protein is the normal non-mutated protein, and over decades deposits in soft tissue, such as carpal tunnel syndrome and the vasculature, and the primary pathologic deposits actually occur in the heart. Patients with a mutant ATTR, they were born with a pathologic mutation in the TTR gene, leading to accelerated amyloid deposition. Mutant ATTR most commonly deposits in the heart and or nerves, with a pattern of deposition largely dependent on the specific type of mutation. In the United States, the most commonly encountered mutation is the V122L type, and it's actually present in up to 3.5% of those of African descent. So this slide gives you a brief look at these different types of amyloid demographics, and we can see that the light chain, males equal females, it can occur in 40 to 80 years of age. It can occur in terms of organ involvement, including the heart, GI, tongue, nerve, liver, soft tissue. It can cause some left ventricular hypertrophy, and because it really represents a malignancy, it needs to be treated with chemotherapy and stem cell transplant. Then we have the wild type of transthyretin amyloid depositions. In these particular situations, the wild type, men are observed to have this situation much, much more often than females. So there's a male predominance. You see it in terms of a demographic between 65 and 95 years of age. Primary organ involvement includes the heart and carpal tunnel syndrome. Left ventricular hypertrophy is very common and very significant, and we'll talk about the medical treatments. The mutant type, still a male predominance, not quite as much as we see with the wild type, tends to occur a bit earlier in life, between 55 and 75 years of age. Heart and nerves and carpal tunnel syndrome are typically involved. You do see this left ventricular hypertrophy in a big way, just as in the wild type, and we'll talk about the medical treatments for this. So this is really a comparison between what we say the hereditary, which is the mutation, and the wild type of ATTR. Pretty much talks about what we have just mentioned already. I think what I'll focus on is at the bottom of the slide, because the prognosis is actually quite dismal without treatment. The hereditary type, the treatment is the survival is only about 2.5 years following diagnosis without treatment. The wild type is a little bit better, but not much better, with a survival of only 3.5 years following identification and diagnosis. The important point also is in terms of heritability. If you actually have the hereditary form over the mutation, it is autosomal dominant, so there's a 50% chance of passage to offspring. So when to suspect it? I'm going to show you how to look for certain signs and symptoms termed as red flags, and they fall into two categories: cardiac and extracardiac. And I remember when I was at medical school at Johns Hopkins University, we actually talked a lot about amyloid, and we called it the great impersonator, because this disease state can impersonate so many other diseases and disease syndromes. Let's talk about the cardiac associations. If you're above the age of 65, HFpEF is actually a very common presentation: heart failure with preserved ejection fraction. Also associated with severe aortic stenosis. a common malady we see as we age, and also hypertrophic cardiomyopathy. So in those situations, you should have a low threshold to assess for cardiac amyloidosis. How about if you're less than 65 years of age? Well, you can still see HFpEF as a common presentation. These patients typically will have moderate to severe left ventricular hypertrophy of 14 millimeters or more in terms of thickness. There's often a discordance between the QRS voltage on the EKG and the wall thickness on imaging. It makes sense from a pathophysiologic point of view because remember, this thickening is not really related to myocardial cell mass, but infiltration of this amyloid protein. So typically you'll see a discordance, low voltage, considering how thick the ventricle is on imaging. Tachy and bradyarrhythmias and conduction blocks of unknown cause should lead to a threshold to consider cardiac amyloid. Intolerance to antihypertensive and heart failure medication, where you find that patients really become more profoundly hypotensive or develop postural dizziness when you're giving them relatively modest doses of antihypertensive or heart failure medicines. And also there can be persistent low-level elevation in serum troponin consistent with ongoing myocardial cell loss. Also elevated natriuretic peptide levels because of the development of this restrictive cardiomyopathy and increases in filling pressures in the ventricles. How about some of the extracardiac manifestations and associations? First off, we do see associated, as mentioned earlier, the neurologic symptoms, typically a symmetric sensory neuropathy with bilateral carpal tunnel syndrome. Patients will complain of paresthesias and numbness. It's also associated with autonomic neuropathy. So you'll see patients complaining of postural dizziness, and they'll have postural hypotension of unknown etiology. In addition, if you get the effect of amyloid in the kidney, nephrotic syndrome can result significant proteinuria. In addition, musculoskeletal extracardiac associations, unprovoked bicep tendon rupture, lumbar spinal stenosis, an affliction many of our patients have, and we just basically think it's the result of aging. But remember, lumbar spinal stenosis as well as macroglossia. Some of the dermatologic manifestations would be easy bruising as well as discolorations of the skin. So this again looks at the cardiac and non-cardiac clues. We talked about the traditional cardiac clues: intolerance to antihypertensives, orthostatic hypotension, this persistent low elevation of troponin, discordance between QRS voltage and ECG and wall thickness, unexplained AV block or prior pacemaker implantation, unexplained LV wall thickening. You may find a thick LV wall on echo in patients who don't have hypertension, et cetera, as well as a family history of cardiomyopathy. And don't forget those non-cardiac clues: the development of neurological abnormalities, sensory motor polyneuropathy, autonomic dysfunction, postprandial diarrhea alternating with constipation, gastroparesis, urinary retention and incontinence, bilateral carpal tunnel syndrome, lumbar spinal stenosis, a more common among the Black race, as well as a family history of polyneuropathy. So this again, I really want to emphasize that these are syndromes and symptoms and signs we see in many of our patients. And again, being repetitive just in order to make the emphasis to look for these signs and symptoms in order to allow yourself to think about cardiac amyloid and go down a diagnostic pathway to either define its presence or absence because of its poor survival and the fact that we now have a treatment for cardiac amyloid. Let's talk about the evaluation and diagnosis. This is really important. First off, you have to have an index of suspicion, and that takes place after a careful history and examination. EKG and echo, we're going to talk about the implications there. You want to go through some hematological screening, which is very easy to do for monoclonal light chains. So you really want to rule out this monoclonal light chain, which is really more of a malignancy in terms of its both prognostic and treatment algorithms. And then we'll talk about using confirmatory imaging, such as pyrophosphate scans. This is probably the most important slide I'm going to show you today. And this really gives a nice algorithm for evaluating for the presence of ATTR. First off, if you have this history, EKG and echo findings suggestive of cardiac amyloid, what's the next step? Well, the next step, if it's suggestive of another infiltrative process such as hypertrophic cardiomyopathy or constricted pericarditis, cardiac MRI may be the way to go. But if it's not suggestive of these syndromes, what you want to do is simply do a blood test for serum kappa lambda free light chain ratio, look at serum electrophoresis, both in the urine and in the blood. If it's abnormal, then that's consistent with a monoclonal protein being detected, and that patient would not have ATTR. So if it's present, that patient needs to be seen by a hematologist with the other diagnostic parameters being evaluated. If there is no evidence for any of these light chains, then we could consider technetium pyrophosphate imaging. If that is consistent with amyloid by virtue of greater uptake in the myocardium than would be seen, for instance, in the bone structures in the chest, such as the ribs, that would be consistent with the presence of cardiac amyloidosis and consistent with ATTR. And then in order to make the distinction whether this is the hereditary or the wild type, genetic testing could be considered. And obviously the important thing with regard to genetic testing is whether the mutation is present, and if so, certainly consideration for evaluating offspring may be reasonable. So I'll just give you another few seconds to look at this algorithm because I think it's very, very important. These are some of the echo findings in cardiac amyloid. What we find is the thickening of the ventricle. Sometimes you can see a glistening within the left ventricular wall. What we see also is this restrictive pattern in terms of mitral valve inflow, and we also see an abnormal strain pattern on cardiac echo with amyloid. Pyrophosphate scanning really plays a pivotal role. And what we can see on the right, you can see the infiltration or the uptake of pyrophosphate, which is much greater than what would be seen in the bony structures, such as the ribs and the spine. And this would be a situation that would be consistent with the presence of cardiac amyloidosis. So the pyrophosphate scan plays a pivotal role in that diagnosis. What we also see when we use MRI, which can also be very helpful, a few things that we can see. Number one, we see the thickening of the ventricle, and we can also see the uptake, what we call the late uptake of gadolinium in a subendocardial type of emphasis. So you start seeing the uptake of gadolinium, late uptake of gadolinium within the subendocardium, and using T1 imaging, we can see with MRI the infiltration of the extracellular matrix within the ventricles. So we see more extracellular matrix versus what we would expect to see with a hypertensive heart disease, which would be greater myocardial cell involvement. So again, the big distinction between amyloid heart disease and hypertensive heart disease is amyloid has the extracellular infiltration of this amyloid protein versus hypertensive heart disease, which is basically an abundance of myocardial cells. So the treatment options, we have basically three different approaches. We have what we call TTR silencing, where we can actually stop the synthesis of the amyloid protein. TTR stabilization, where we can prevent it from going from that the tetramer to that misfolded monomer. And then TTR disruption, where you can actually disrupt the amyloid protein. Light chain amyloidosis, since it really represents an underlying hematological malignancy, really will be approached by the oncologist, and we're not going to really talk about that much more. So we have these different approaches: suppression, where we actually suppress the synthesis of the transthyretin protein, and we have the stabilization, and there's a new agent that has been shown to be effective in terms of stabilizing the tetramer, so you don't go further down this situation, getting to the misfolded monomer, which then is taken up into the variety of cells, such as the cardiac cells, the myocardial infrastructure, as well as the nerves. And then we have TTR disruption. So the TTR stabilization is with tafamidis. It was recently approved by the US FDA. It's indicated for the treatment of the cardiomyopathy of either the wild type or hereditary transthyretin mediated amyloidosis in adults to reduce cardiovascular mortality and cardiovascular related hospitalization. What it does, it actually binds to the protein at the thyroxine binding site. This stabilizes the tetramer and slowing the dissociation into the pathologic monomer. This step is the rate limiting step in the amyloidogenic process. And this is just looking at the pivotal data showing the effect of tafamidis. And what we see here is on top is a mortality reduction, a cardiovascular mortality reduction. You can see in the lower slides an increase in terms of functional characteristics, an increase in 6-minute walk distance, as well as an enhancement of quality measures by the KCCQ assessment. So we see here the improved effects in terms of mortality and in terms of quality of life with tafamidis. We do have the TTR silencing approach, and these are mainly used for the patients who develop the neuropathy. Again, this targets hepatic synthesis of the TTR protein. One compound is patisiran. It's an intravenously administered small interfering RNA that degrades TTR mRNA. So without the mRNA, you don't get protein synthesis for that particular targeted protein. It's indicated for the polyneuropathy of hereditary transthyretin mediated amyloidosis in adults. Another agent, inotersen, it's a subcutaneously administered single-stranded antisense oligonucleotide that binds to the TTR mRNA, leading to its degradation. It's indicated for stage 1 or stage 2 polyneuropathy in adults with a hereditary pattern of ATTR. And both therapies result in about 85% reduction in circulating TTR protein. So these are the studies looking at these particular agents. The Apollo study showed improvement with neuropathy. Unfortunately, in the study performed, we did not see any great cardiac effect. This is looking at the inotersen treatment in patients with hereditary transthyretin amyloidosis. What we do see is effectiveness with regards to the neuropathy, but in this particular study, no real benefit in terms of left ventricular mass or other measures of left ventricular function. So this is really a nice central illustration from the Journal American College of Cardiology. It talked about the fact that that we need to recognize transthyretin amyloid cardiomyopathy. And I did show you some of the tips in terms of being able to identify it. In terms of recognition, we can see that as of around 2014, we're seeing a lot greater recognition, particularly of the wild type. We talked about non-invasive scintigraphy in terms of being very helpful for the diagnosis, particularly pyrophosphate scanning. We talked about treatments in terms of cardiomyopathy. Tafamidis, which has been approved by the FDA for cardiomyopathy, is really is really your best option. When you start having cardiomyopathy and neuropathy, you can look at both tafamidis with the other silencing approaches, and for neuropathy alone, it would be the silencers, which would be patisiran and inotersen. So in summary, amyloid heart disease is common and often missed. We talked about the clinical pearls looking for both the cardiac and extracardiac manifestations that you really need to be on the lookout, because we're talking about a disease state with a very poor prognosis. And now we have a treatment for both the neuropathies and the cardiomyopathies. It may be responsible for up to 20% of cases of heart failure with preserved ejection fraction. You need to be aware of the patient type, and certainly those certain situations that we just talked about, to identify those patients that developing high risk of cardiac amyloid. And those situations include those patients where you think that they may have HFpEF, they may have a hypertrophic cardiomyopathy, aortic stenosis, and certainly the associated non-cardiac manifestations, particularly the presence of bilateral carpal tunnel syndrome, postural hypotension, extra sensitivity to heart failure, vasodilators, and blood pressure medications. We reviewed a diagnostic algorithm that can be applied in clinic. We talked about amyloid heart disease having the poor prognosis if untreated, basically survival rates between 2.5 and 3.5 years. Important innovation, tafamidis, an amyloid protein stabilizer, has been shown to improve events for patients with amyloid cardiomyopathy, and therefore it has the US FDA indication for the treatment of amyloid cardiomyopathy. And we'll have to wait and see if new treatments using mRNA technologies that actually block the synthesis of these amyloid proteins, whether they actually alter the course of amyloid heart disease, as they do seem to alter the course of amyloid related neuropathy. Thank you very much for your attention.